right, everyone. Thank you to our panelists and moderators. We really appreciate it. I'm going to welcome back Dr. Seshkin to the stage, Dr. Tamar Seshkin, to moderate our next session, A Disease Without Borders, Why Endometriosis Requires a Team Approach. I'm going to call up our panelists as I introduce them as well. Feel free to head towards the stage. McCall Huey is a passionate advocate for those facing endometriosis, diagnosed with stage 4 endometriosis in 2019. McCall now serves on the EndoFound's Patient Advisory Committee, empowering women to advocate for early intervention and personalized care. McCall, come on up. All right. Next, I'm going to invite Camille Winter up to the stage. Camille is a lawyer specializing in anti-money laundering and terrorist financing compliance at an international bank. She's a native of Jamaica who immigrated to the US as a child and began experiencing the effects of endo at just 13 years old. After suffering for 20 years from endometriosis symptoms, recent surgical treatment has provided renewed hope and is helping her to reclaim a quality of life previously stolen by this disease. Welcome up to the stage, Camille Winter. Last but absolutely not least, Stephanie Christian is a passionate advocate for women's wellness, an Ayurvedic counselor, Reiki facilitator, teacher and master, and an advanced essential oil specialist with over 12 years of experience in alternative holistic therapies. Please welcome to the stage, Stephanie Christian. And then Dr. Seshkin, our moderator.
I will stick to my time, our time. This is the most critical part of reality you should know. Endometriosis surgery is not a joke surgery. It's the most serious surgery. It is worse and much difficult than cancer surgery. A lot of people getting away with their own things, and nobody, if you go to these international meetings, even you look at their agenda, nobody talks about the issue of unintended consequences of endometriosis surgery. And if you even get consent in your doctor's office and things like that, nobody talks about the real complications. This is really how you can prevent complication, how you, despite every measure you take with endometriosis, you still have unintended outcome after surgery. I honestly heard, of course, I'm not going to point to them, but there are 2 patients in the crowd who have bags that you won't know who they are, and they're carrying it for a while. And there are people who will talk about bags here. I have a patient I operated 10 days ago. It's 10 days exactly. Came with a cane, who could not walk, had his 3-4 hysterectomies in the most prestigious places in the United States, and they couldn't do it. She is here walking right now. There is a reason who does the surgery, why. And it can't be one person. It's not fair. One person is not enough. Surgeries are long. There's something called surgeon's fatigue. One surgeon cannot see everything. Yes, Elon Musk is crazy, but he did something that a human can. He's doing a driverless because he's got all the experience communicated. He has loaded into computer. He knows exactly every spot that can cause problems. So humans are very, subject to not doing perfect. Even then, that's why we're here today. I have wonderful panel here. I hope I touched the question issue right. Do I have this? So I'm glad you're joining us. I know you, all of you, and I want to start with the youngest on the corner, that she will tell her story and why other stories are, how that relate to your story. Your story relate to it. You're really sisters of the same consequences. Somewhat you have different outcome than theirs. Yes, I give you the microphone. Do you have a microphone? Do you know how to make that work? Okay.
Hi, everyone. It's nice to see you. Such an important cause and a great day. So
Close to your...
really thrilled to be here. So I hear these amazing stories of women who knew there was something wrong, sought multiple physicians' opinions, advocated for themselves until they got a diagnosis. And briefly, I couldn't have had more of a different experience. I remember when I was starting my menstrual cycle, 11, 12, I went to my OBGYN, and she said, I know you started your period, and how's that going? And I said, I'm in extraordinary amounts of pain. And she said, yeah, more or less, every single woman is going to feel the exact amount. So you're all no different. Just find something that works for you. And at 12 years old, I never questioned it again. I just lived with it. I never thought for an inkling of a second that there was something bigger at play. Until I had an emergency surgery in 2019 to have a cyst removed, to which I then learned of the word endometriosis. I hadn't ever heard the word before. I'm Googling it with my mom in the hospital bed. And then I later found Dr. Sechkin a few months later, and he did a 6-hour surgery, removed 51 endometrial lesions. I had an appendectomy and a bowel resection. And ultimately it just completely changed my quality of life, but certainly like the bowel play, I had had a lot of IBS, which he calls IBS, which it is, trying to figure out what that was. Now I look back and feel silly, having not connected the dots sooner. But certainly for me, bowels and diet and all of that really was affected and what led to my stage 4 diagnosis. So for Winnie talking about diet and all the things, that really rings true and clear to me, because those are things that I also struggled with and had to sort of find balance of my own diet and try and error and all of those pieces.
Thank you. I think the reason why she's on stage is I asked him personally, because this is a young age diagnosis or very advanced endometriosis. Ladies, endometriosis is progressive disease. It does progress. Not in everybody. In some people. That's why we are here for. That's where molecular medicine, genomics does make difference. There's a difference of their endometriosis than you heard about silent endometriosis or fertility-seeking patients who have nothing to be found on sonogram. They're all looked as normal patients. This is different. That's why we're doing this session. Your mother should know, your doctor should know better. I should know better. Because of me, you should know better. So that's an early diagnosis. I know what I know and I can share. What story touched about me? She is a very smart girl from Texas in law business here. I've never heard anybody what she does in law business. She can say that if she wants to, but I was very impressed. What I was impressed more to her story. It's not her mother who is here, obviously supported her, but when she said, my father never believed me, when he learned that, he started to cry. I like to hear those fathers who cry, because they have different opinion of girls and wives differently. And I'm one of them too. I mean, when I move into my house, maybe I'm a different person, I have to admit. For all things, I apologize. My wife is not here, but that's okay. So, moving on to next patients. It's important to talk about complications. I have patients who went back to surgery because they had post-operative bleeding. Despite we do everything, they accumulated blood, we rushed them to surgery again. Or they came with fistula, we repaired fistulas. There's no fistula I didn't have, and I repaired them. So people come with bowel obstruction. And I am going to present another lawyer. She's a scary one, a anti-money laundering lawyer. Here we go. You're going to hear her story. And I operate on lawyers. I'm not afraid of them.
Your money is safe. I only care about banks, so it's okay. So when I saw Dr. Sechkin recently, I had 2 bowel obstructions. So my endo journey started very young as well, 13 years old. A lot of painful periods, but it presented normally, cramping, back pain, but over the years it got worse, and it was mostly rectal pain, rectal bleeding. And I would go from GYN to GYN, and they would tell me, oh yeah, you have endo and all these things, but we can't do anything about it. Your best bet is to just stay on, birth control and do pain management. So I did pelvic floor therapy. I did everything I could, and then it just wouldn't get better. And then it got to the point where my colon was 90% blocked. I couldn't eat. It was painful to eat, painful to use the bathroom. It just impacted my entire quality of life, and I was having symptoms outside of my period, like a lot of leg pain. I couldn't sit for long periods of time. At that point, I didn't know that my endometriosis had spread throughout my rectum and throughout my large intestine. So after 2 bowel obstructions and dealing with insurance companies that would approve one surgeon and deny another surgeon because I needed not only Sechkin, but a team of surgeons to help me, I finally was able to get the surgery that I needed, and it has made, I feel like a completely different person. I feel mentally stable, and for the first time in over 20 years. And so I say that to say that I think the biggest takeaway for me was, finding doctors that knew that endo impacted my whole body and not just my reproductive organs.
What I think, I don't know if you intentionally omitted, but there is a reason also why you had multiple professional, specialists in your care. You came back to hospital for something.
Yes.
Do you want to talk about that?
About the ureters?
Yeah.
Yeah.
She had a complication.
Yes.
She had a fistula. After 11 hours of surgery, this was her second surgery. The first one, her surgery was 7 hours, right?
Yes.
And she came, may I talk?
Yeah, go ahead.
And suddenly, she wanted surgery. Suddenly, I got a call from North Westchester Hospital. Sechkin, your patient is here. What's going on? She's obstructed. It's either very inconvenient time to get my staff together, and the guy over there, very respected guy, who was here before, he said, I don't want to touch her. I just don't want to touch her. Okay, fine. So what do? They put can I say?
Yes, a stent.
They put stent, rectosigmoid stent, like you do to the heart, so the blood can flow. So lots of cardiothoracic surgeons lost business because of that, because we do stents now. They don't need major surgery. So they put rectal stent. She came back to our hospital with a rectal stent, so she doesn't get obstructed. I have, unfortunately, I have those pictures. I do present your case without mentioning to others. We have other patients like that too, but it's very interesting. She came with a stent, and surgery took 11 hours, and 7 days after or so, she came back with a fistula. From ureter, there was so we put stent again, and then it was removed. You're doing fabulous to find. So it's another complication. These are 10% of the advanced cases on the average. I presented yesterday, 1 in 10 things go south. You have to know that. But it has to be within the realm of the team that can manage that. Here I have another story. Stephanie is a nurse, has been long patient. I forgot how many surgeries I did for you, but I have done 5 surgeries, but I know her for years. For years. She will tell her story, and it's a remarkable story, and she really suffered so much. I felt so much for her, but it is one of the things that you should also know. Realities cannot be hidden. Go ahead.
Yeah, so, gosh, my journey with endometriosis started back in 2010 officially, and I say officially because for a long time before that, I was absolutely lost at understanding what all of my symptoms were and where they were going to take me. I honestly thought that the first time that I had endometriosis surgery done by my regular gynecologist was something that was removed and I didn't have to worry about it anymore. And it wasn't until a little bit later on, like maybe 3 months after, my pain returned. And I was like, I thought I had this removed. I didn't think I would need surgery again. And then I started to read. Back then, endometriosis wasn't a word that was commonly known. I had not even known about it until I had an ER doctor who was a friend that I went to college with sit down with me and say, hey, your symptoms sound like endometriosis. Well, fast forward, we found Dr. Sechkin, who did my first surgery, and I think I had 19 cassettes that were positive with endometriosis then. And I thought, okay, great. like, again, in my head, thought, I'm good. Well, 2 years after that, and 2 years after that, the surgeries piled on, but I had different complications because once that endometriosis had been moved around initially, it was starting to be around the bowels. It was attaching my rectum to my uterus quite often. I also had ureter surgeries where I had a stent and a catheter. And then fast forward, what I thought would have been the final surgery, and I thought that this time we were going to be able to plan it. I wasn't able to plan it, and I had to be rushed in during that week for a hysterectomy. And, you know, I was okay. I had, at that point, realized that this was going to be a part of my journey with endometriosis, that this hysterectomy was going to happen. I knew that that's not the end-all and answer-all. However, we had a beautiful surgery, and a few days later, I had to call Dr. Sechkin. And so I ended up going back to the hospital near me. Dr. Sechkin was on travel at that time for his birthday, actually. And I had to trust a team that was at the ER at the hospital near me. And I ended up in the hospital for 45 days. More than half of that time, they didn't know if I had time. Every day, running those labs. And then created a team behind the scenes with Dr. Sechkin and other doctors that were on board, that were able to read all my reports daily, and then let me know how I was going to do the next day. So here I am.
So the bowel-related surgeries and their complications are potentially could be fatal even if you're not in the right hands, not managed well. So reversal of the bowel resection or colostomy is very, very important. Not everybody can do it. It has to be done by really, really caring and gifted individuals that work together. All right, we have teams of bowel surgeon, vascular surgeon, and urologist also, and more important, even liver surgeon. We work together, but I, being the most experienced eyes and with this disease, they don't have that experience. They do not recognize the disease. Really, they cannot, and they miss things. And because we are gynecologists in general, there's an attitude. You're a gynecologist, what do you know type of attitude. In my hospital, that doesn't go that way. Dr. Adikas would testify to that. I'm the boss in the surgery in my patient. If I'm bringing the patient to the room, I make that decision because I have more experience than them. That designates a team. And I need other doctors to be like that because they do liver transplant maybe, or they do this, but they don't know endometriosis. A thoracic surgeon, he's excellent, but he misses that little hole on that diaphragm, and the patient goes back to hospital 15 times. There may be thoracic cases here. How many of you had endosurgery, had very difficult recovery or complications? Oh my God, look at this. There's a reason you're here. I counted at least 15, 20 arms here. So this is the part nobody talks, and we have to talk about it. There's nothing wrong. This is going to make doctors to train better and be more tedious and teamwork oriented than every little corner hospital. Anybody who has a scope goes in and do things and build the insurance company and, okay, I don't want to see anymore. I think the most important critical part of endometriosis care or surgery is not the surgery really, it's after surgery, the care and what you instruct people. I typically tell patients who are coming from Toronto or anywhere outside of New York City even, stay around 10 days, 7 days, please 7 days, a week. I want to know when you move your bowels, make sure you're not having any temperature. Bye-bye, have a nice travel back home. That's the way it is. Otherwise, if they end up in another hospital, even in New York City, you don't know who's on call in that emergency room that night. It's usually, you know, traveling doctors or moonlighting doctors from somewhere else. He will do the job. You'll never see him again in your life. And hospital will be fine, everybody, but you will be, unfortunately, with Stephanie, that has been the case, but I visited her in the hospital multiple times, and she is here with us today, and I'm so proud that she's doing very well. Thank you.
Grateful to you.
I don't want to go over time. I like to take questions because this is a very important part, and we have time, right? Another 5 minutes, 10 minutes? How are we doing with time? Any questions in the audience, please? There you go, ma'am. Can we give the microphone, please?
Hello. My question is for a few people, I believe have the same one because we were discussing it, is affordability and accessibility. That's one of the hardest things I'm coming across. I have comorbidities. I have 31 years with Crohn's disease, and I just got diagnosed with endometriosis. I'm disabled on Medicare and Medicaid. Finding some of the best doctors like you that I would love to have on my team, unfortunately don't take my insurance. How do I go about doing that? I know some doctors have some great programs, some sliding scales, and other things like that, but it's hard being sick and poor. It is a full-time job doing this. And I'm sorry getting emotional, it's really, really hard. I'm so thankful for this conference.
I got you. The question is very clear.
Sorry.
This is the eternal question. I appreciate you bringing it. So that's why this foundation exists, number one, all right? I can't, obviously, time-wise, we can't operate in every patient. The problem is, you know, we have a conduit through the foundation. If you write the foundation, and I will find the right people that we can operate you in our hospital. I'm saying this, obviously, we will pick cases. You know, I like to offer patients who have obstructive bowel disease, who has sciatic endo, chest cases. I will do everything their foundation will ease the conduit for them to get treated. And you have my word for it. There are people who I do
Thank you, and God bless you
surgery.
for what you do.
I want you to know that. I know not everybody can afford certain things, but not every doctor can afford the malpractice insurances I pay in the heart of New York City also. You know, let me tell you that.
Thank you.
I appreciate the question. I was going to answer you before, actually. I heard the similar question before.
I'm
but
blessed
this
that
pops out all the time. And we have done so many cases throughout. And there are also wealthy people who also subsidize this. But we didn't want to make it like a open public announcement that our channels, there's openings in the channels. Hopefully it's going to get better. But we have to push for it. You're right. I mean, especially cases who are truly debilitated, cannot find the right doctor to have one. All right? Go ahead. Any
Thank
questions?
you.
Yes, ma'am.
Thank you again for everything you do with EndoFound. So grateful. My question is about ablation versus excision. As far as I know, when I last checked, they're still coding ablation and excision the same through insurance. Are you feeling hopeful at all that moving forward there'll be more surgeons that will teach surgeons to do excision, so there's more accessibility?
Let me tell you the real problem. I know the people who were in that committee of ablation versus excision business, and who really coded endometriosis, the most common and the most misdiagnosed, the most mistreated, the most mismanaged type of endometriosis is the peritoneal endometriosis. And these people, they are my friends, I consider them, but professionally we are at the other end of the stick. They are in academic medicine. I'm in private medicine. I spend 1 hour with my patient. They spend 15 minutes. They don't see much peritoneal endometriosis. See, they named peritoneal and the real peritoneal endometriosis, which is most common and many suffer, as superficial endometriosis. Right. When it is superficial, I am telling you, your disease is superficial. So that means it's not as important as deep, It's not important at all. It may not be even there. They put that in the coding. I can't believe what they did. They cut the branch, the most important branch we're standing on. So we need to reverse that. The coding is wrong, and the coding does not refer to the real disease. I mean, there's no way you can tell if the superficial does not designate the dissemination of there are maybe 50 lesions, and there may be also deep too, but who's there to say it's deep or whatever,
Right.
to justify? So we need to correct that. We started to in that thing, we have a lot of work to do. And insurance companies loves it because
Right.
they want it to be called superficial, so that they don't pay you.
Well, doesn't
so no
it
doctor
usually-
does the procedure,
It
and they
usually
don't get
results
better.
in more surgeries, though, like a lot of women who have ablations first and then can find care. Like,
Do you
your
understand the
place.
difference? Everybody understand difference between ablation and excision? I'll make it for the record. You know, in breast surgery, it is always that small, one very little tiny lesion that could be cancer, right? If you don't do the right approach to it, the patient may have sustained breast cancer, right? The word is excision surgery. It's been traditional for 150 years, 60 years like that. I actually learned excision through that because I had the opportunity to work in that kind of business. But it should be excision when you remove the whole disease with border-free to the point that you don't, the whole rationale, you don't leave disease behind. And you can easily not see all the lesions if you're not trained. Most lesions are not pigmented. In other words, they're not black. They're white and off-white, and under the bright, under the blinding effect of the brightness of the light we use, we miss most of those lesions. My pathologists say, how did you find, there was only one gland there. How did you find it? I winked at her. I didn't see it. I only removed the white area. You found that one single gland there. But for patients though, it is so important. The word is validation. I mean, how many lesions you removed by excision is so powerful. It's a big step towards vindication. I was right. This doctor, I loved my doctor, but how did he miss this? He did miss it because there's a different way of seeing it. And unfortunately, when doctors know everything, they don't have to learn anymore. That's a big problem, right? I really thank you. I stole the microphone from you. But do you want to add something to the rest of, just say something, just closing for the rest of the people who may listen to this tape later in life.
You want to go first? I would say what made a difference for my journey was learning the disease for myself. And days like this and foundations like this help facilitate that, because by knowing the disease and how it works and how it impacts your body, you get to weed out those doctors that really don't want to learn and want to know and don't want to know more. And then it prevents you from putting up with years and years of subpar care. And if there was one thing I could have changed about my endo journey, was that I put up with a lot of doctors that didn't care about me, that didn't listen to me. And it wasn't until I found my current doctors that I felt heard. They understood everything, that no matter how unique my symptoms, they could explain it. And they built a team to address the way endo was impacting my whole body. So the more we learn about the disease, I hope more doctors are interested and want to learn and don't feel like they know everything, and that they don't just give us the bare minimum when we go and say, I have period pain, I have bad periods. So I just really hope that foundations like this and days like this can just change the way everyone views this illness.
I'm just going to say that if you end up ever having a complicated surgery or end up in the emergency room, take it step by step. Take it breath by breath. Know that you're here on this planet for a reason. Whatever your purpose is, you're here. And if it is for patient advocacy, if it is for your own advocacy, learn to listen. Listen to the relationships around you. Communication goes both ways between the doctors, between the patients. and between your team. So listen and communicate well.
Thank you.